A rare bug in the blood. A case report of Solobacterium moriae bacteremia in an immunocompromised patient treated with 7 days of metronidazole. This was a case of a 57-year-old male with a history of renal transplant on immunosuppressive agents who was treated in the medical intensive care unit for pulmonary blastomycosis, requiring mechanical intubation. Midway through his treatment, on MICU day 7, the patient developed bandemia, increase in band cells from 1,000 to 10,000, with difficulty weaning his ventilator requirements, prompting repeat infectious workup. Blood cultures resulted with 1 out of 2 anaerobic bottles growing Solobacterium moriae. Transplant infectious disease team was already on board given the patient's kidney transplant history, and they recommended a 7-day course of metronidazole, 500 milligrams twice daily. Repeat blood cultures demonstrated clearance after 48 hours. He was never febrile. Leukocytosis and bandemia downtrended after starting metronidazole. The patient recovered and was liberated from the vent on MICU day 15. Solobacterium moriae is a non-spore-forming, anaerobic gram-positive bacillus. It is a part of normal oral and gut flora. It was originally isolated from feces and has been associated with halitosis. It is more commonly reported in the literature when isolated from dental or wound infections, but rarely associated with bacteremia. Detection of this organism requires DNA sequencing. Anaerobic bacteria comprises only 0.5 to 13% of bacteremia cases. From my literature search, there are less than 20 documented cases of Solobacterium moriae bacteremia. Other cases describe treatment of this with broad-spectrum antibiotics and/or for a longer duration, ranging from 10 to 35 days. Our case demonstrates monotherapy with metronidazole for 7 days, which provided clearance of blood cultures and clinical improvement. I have depicted several examples of cases of Solobacterium moriae bacteremia reported between the years 2006 to 2019. For instance, one case utilized piperacillin tazobactam for 15 days. Another used cefuroxime followed by metronidazole for 27 days. There were other documented cases which reported their antibiotic selection but did not clarify their duration of treatment. Examples of this was using vancomycin plus meropenem, benzylpenicillin followed by phenoxymethylpenicillin, and amoxicillin clavulanic acid. Given the low incidence of this bacteremia, it is helpful to share effective antibiotic regimens with duration. This is significant as utilizing more narrow antibiotics for a shorter duration decreases antibiotic resistance and lowers risk of adverse effect or toxicity. This case will hopefully serve to describe rare bacteremia management and provide information to guide future cases. Thank you.